Mr. Chairman, ladies and gentlemen, thank you for coming at early notice, and I would like to thank the association for giving us a chance to present our work here today. Causes of peripheral pulmonary artery stenosis is variable between acquired and congenital, syndromal, atherogenic. It's a long list, and they all end with the same pathophysiology. It's a progressive pathophysiology that will end ultimately with RV dysfunction and dilatation, cyanosis, and sudden death. It's a very dismal prognosis if you think about it. We decided to approach this in a very systematic approach in King Abdulaziz Cardiac Center, where we constructed a pulmonary artery reconstruction team. These pathologies are all channeled through the same program and pathway. This is a multidisciplinary team of surgery, cardiology, anesthesia. They're all in the special interest of pulmonary artery pathology. All patients are managed in a consistent approach with a very fixed management protocols, with a prospective collection of data and a feedback to make changes. All patients are referred through this pathway for diagnosis, management, and for follow-up. This is the demographics of our patient. The spectrum is very wideable, as you can see, from 1 week age to 10 years. The weight extends from a 2.6 kilogram neonate to a 30 kilogram. Male, female gender will basically equal. The pre-op RVSB, all our patients, they have pulmonary hypertension or RV hypertension, systemic or suprasystemic. The symptoms variable from asymptomatic 5% to the majority being symptomatic. We currently only operate on very advanced cases. The cyanosis is 75%, severe RV failure 20%, and take on. The majority of our operations, 50%, is unifocalization for pulmonary atresia VSD MAPCA, and about quarter is something we call total pulmonary arterial reconstruction. And around quarter is a two-stage lung salvage procedure that we will discuss, and others. This is the distribution of the cases. Over the last 3 years, we did 61 complex pulmonary arterial reconstruction on 47 patients. This not included 3 cases that was done in March. The distribution of the diagnosis, as you can see, is quite variable. Pulmonary atresia VSD MAPCA is the majority. Ductal origin of the pulmonary artery, 11 patients. Arterial-Schwartz syndrome, 6 patients until February. We just did the 7th patient. Williams syndrome, 2 patients, and others, and others, and others. And 1 case of a congenital diffuse calcific pulmonary arteriopathy that until this moment we cannot classify it. Complex pulmonary artery reconstruction was done in 47 patients. Around 50% were a single stage. Those are patients with adequate pulmonary arteries and adequate collaterals. Patients with hypoplastic pulmonary artery or no native pulmonary artery and inadequate collaterals underwent a staged repair. 25 patients for a percentage of 53%. There was only 2 patients who lost interstage mortality after being discharged. Those with a shunt physiology. And the majority of those patients underwent a completed repair, and we still have 13 patients waiting for stage 2. Let me simplify this. This was a non-selected groups of patients, all comers. No patient was rejected on the basis of anatomy. The complexity of the pulmonary artery anatomy was never an issue. Only 5 patients were rejected from the program due to delayed presentation. That's the cornerstone. That's the real problem with those patients. Delayed presentation after the development of pulmonary vascular occlusive disease is the main reason for rejection. Autologous tissue-to-tissue connection was achieved in all the patients. Survival, the operative survival is 100%. Survival discharge is 99%. 1 patient died due to severe form of reperfusion injury. 1-year survival post-discharge is 96%. As I said, 2-stage interstage mortality. 1 patient died due to sepsis in a peripheral hospital 9 months after the surgery, and 1 patient died with infective endocarditis 4 months post-op in a peripheral hospital. 2 patients underwent ECMO for severe pulmonary reperfusion injury for a percentage of 4%. Both completely recovered, survived, and left the hospital alive and still alive. The total number of reconstructed pulmonary artery segment was 401 angioplasty. This is a mean number of segments reconstructed per patient of 8.5 segments, plus minus 6.4. The range is 3 to 29. That's a total pulmonary artery reconstruction. Recently, we're doing more and more of this. All patients who completed the repair had a normal RV pressure, defined by less than 30% systemic, except for 1 patient with the idiopathic pathology that we could not classify, who came with a suprasystemic and severe cyanosis, left the hospital with a 65 to 70% systemic blood pressure and normal saturation or room air. Reintervention rate. Overall freedom from reintervention is 93%. Freedom of intervention for pulmonary artery restenosis per patient is 96%. Per P angioplasty is 99%. Let me explain for you the figure. 93% is reintervention that include 2 RVT pulmonary artery conduits scheduled accordingly. Catheter intervention in 2 patients requires 4 stents out of 401 repair angioplasty. That's why the 99.9%. Let me take you through. The unifocalization procedures have a very systematic approach at the time of diagnosis and very systematic protocol that we follow and rigid for the surgical intervention. This is an example of one of the cases. 10-month-old female presented to us with the 4 collaterals. There is no native pulmonary artery in this case. The collateral were hypoplastic and full of stenosis. She underwent a stage 1 bilateral unifocalization to a central shunt, and stage 2 came later. This is after stage 1, 6 months later. You could see the difference between these collaterals connected to make a pulmonary arterial tree. This is just before stage 2. She underwent a stage 2 closure of the VSD, RVT pulmonary artery conduit, and post-op you could see the pulmonary artery conduit, the 2 pulmonary artery good size, and the RPA gradient is nil, the LPA gradient is nil, and the TR gradient is not significant whatsoever. We're following her up this specific example for 2 years. She has an excellent RVSP and cardiac function. Her lung perfusion scan is near normal, 50 to 50, both right and left. And there's a lot of these examples. We basically cath most of those patients by 1 to 1.5 years as a routine follow-up. The total pulmonary artery reconstruction makes about 25% of our program. This is a single-stage extensive surgical correction of diffuse stenosis and or distortion involving the main pulmonary artery, RPA, LPA, lobar, and segmental pulmonary artery. As of this stage, we don't operate on subsegmental yet. Experiences include 11 patients with 100% survival, arterial tortuosity syndrome 6 patients, Williams syndrome 2 patients, tetralogy fellow with severe diffuse peripheral pulmonary artery stenosis 1 patient, and atherogenic. Arterial tortuosity syndrome is a rare autosomal recessive disease. For some reason is common here in our region because of the consanguine marriage. 6 patients all presented with severe diffuse bilateral pulmonary artery tortuosity and stenosis, systemic or suprasystemic RV pressure, RV dilatation and failure. 1 patient also had severe aortic arch obstruction that presented at the age of 6 months. This is example of case 1, severe RV failure and dilatation. You could see the dye collecting in the MPA, severe stenosis in all the lobar segmental branches. This is LPA, RPA. Case number 2, you could follow tortuosity, stenosis in all the lobar, and also you could see tortuous left pulmonary artery and stenosis in the rest. Case number 3 is similar thing, follow the same pattern. Case number 4, you could see the RPA, tortuous, aneurysmal, stenosis everywhere. The LPA apply the same. This is the case with aortic coarctation. This is the arch, severe aortic coarctation, and this is the pulmonary artery, severe stenosis in the peripheral branches, the left pulmonary artery and the right pulmonary artery. Case number 6 is the same. Severely tortuous right pulmonary artery, stenosis. This is the right upper lobe, complete interruption, then stenosis. This is the left pulmonary artery and the right pulmonary artery. All the 6 patients have been operated in a single stage. All had 100% survival, and all of them had a right ventricular systolic pressure post-op less than 30%, complete recovery. We're following them up. They're all doing well. This is one example of those patients that we had a post-op angio. This is pre, and this is post. And this has been published. The 2-stage lung salvage procedure indication are in children with complete interruption of branch pulmonary artery for a ductal origin or atherogenic. We have an experience with 9 patients, 6 completed 2-stage, and 3 are still in the interstage. Again, we have a very fixed protocol to follow for those patients. And this is an example of 1 patient, 8-month-old girl, underwent unifocalization elsewhere, complicated by loss of the right pulmonary artery. This is the conduit, the LPA, and the RPA nearly interrupted. She had a suprasystemic RV pressure with complete RV failure to thrive, and spent her whole life in the ICU. This is her right ventricle. You could see severe dilatation and near failure. This is her pre-op lung perfusion scan. You could see the left lung, and nearly there is no perfusion of the right lung. She underwent 2-stage procedure. At the operation, stage 1, we found the RPA occluded all the way to inside the lung. We followed the lobar branches. The right pulmonary artery size was about 1 millimeter, with the 3 lobar branches literally less than 1 millimeter. The 3 lobar branches were joined together to form a stump, and then this was connected to a central shunt to the ascending aorta. This is stage 1. 5 to 6 months later, exactly 5.5,